Good afternoon, everyone, and welcome to Learning Lounge 1. My name is Oscar Guzman. I lead the medical affairs team at T2 Biosystems. And so welcome. Thank you for taking time out of your schedule to be here. Today we have a great crew from the University of Louisville. We have several speakers for you today. We have Dr. James Snyder. He is the Director of Microbiology, Infectious Diseases, Molecular Diagnostics. We have a team from the pharmacy department, Ashley Rose. Dr. Rose is clinical pharmacy specialist, infectious diseases, PGY2, ID program director. And then we have Dr. Milby. Dr. Milby is a PGY2 infectious disease pharmacy resident, also at the University of Louisville. And today they'll be speaking on the clinical impact and innovations of culture-independent diagnostics, a multidisciplinary approach for real-world applications. So give them a warm welcome.
Thank you, and thanks to the audience for your participation today. The title is somewhat misleading. We see sepsis, but we also have to remember bacteremia and fungemia as well. And we're going to talk about, to a certain extent, our experience and what I call stewardship. Now, conflict of interest, these are some of the areas of topics we'd like to cover for you, to go over the principle of operation of the T2 system, list the targets that are currently available on the system, and how we think the optimal utilization of the technology from our perspective is of great benefit. Now, we adopted the philosophy approximately 5 years ago in planning for the future of our clinical laboratory that rapid diagnostics is going to drive our planning. So why rapid diagnostics? Well, the sooner you can get the answer, the better. What does that translate into? Hopefully, improved patient management and antimicrobial stewardship. As you know, culture remains the gold standard, but it does have a low sensitivity. As a result of that, it increases your turnaround time with regards to final results, defined as positive culture, identification, and at least 36 hours to get susceptibility results in a final report. The idea is to initiate appropriate therapy for the purpose of reducing mortality and morbidity. I look at it from the perspective it's our obligation to support antimicrobial stewardship. Very, very important. In other words, decide, can we terminate therapy, escalate, or de-escalate, all based upon the results that the clinical microbiology laboratory generates. Obviously, to promote the unnecessary use of both antibiotics and antifungal agents, which can lead and do to poor outcomes, length of stay, and so forth. I'm often reminded by our administrators, you're costing us a lot of money. Not true. The monies that are spent on length of stay or hotel costs, antibiotics far outweigh what it costs us to do the assay. And that's sometimes a very hard concept to sell to administrators. So we do support the sepsis program. We are a core laboratory for 8 institutions, 5 of which are hospitals. 4 of the 5 hospitals have adopted and added T2 to their sepsis bundle, and that's the most recent activity in the last 3 months. I think this breakdown is very, very representative of why we want to get those results as soon as possible, to promote clinical outcomes for the very reasons that are stated on this slide. That is our obligation as a microbiology laboratory. That's why you'll hear me at the end say it's a team effort. These 2 ladies sitting in front of me, we're all team. We work together. They support us, we support them. They challenge us, we challenge them. So every day is a party at our place. An overview of the T2 system itself As you can see, there are 3 panels, the bacterial panel and the respective organisms from the Canada group that are currently on the target base. The T2 bacteria and Acinetobacter was recently added. And then the T2 resistance panel, which is awaiting FDA approval. That will make a big difference once that becomes approved, and we can combine that with our bacterial panel. Results are usually available in less than 5 hours. There's no sample preparation, so if you will, the tech time is minimal. And of course, administrators look at labor costs. Virtually no labor, or less than a couple minutes for preparation. Sensitivity is very high. I even told T2, excuse me, 1 colony forming unit is sometimes opens the door for questions from me, but it is highly sensitive. That's the key factor. And the nice thing about it is not inhibited by antibiotics, and I will go through some of the interfering factors that will jeopardize results coming off of the T2. But once again, the organisms you see here probably account for close to 80% of the bacteremias and or fungemias. I have a couple slides with schematics regarding the principle of operation. It requires a 2 ml blood sample to be added to the test cartridge. Once it's loaded into the instrument, the red blood cells are lysed. The concentration then leads to lysis of the organisms, be it yeast, be it bacteria. That lysate is amplified and then hybridized with specific probes. And then the detection starts. And as I go to the next slide here, you can see we draw a 4 ml blood sample in an EDTA tube. 2 mLs of that, as I indicate, are going to be used for the actual testing. Once again, we go through the cell lysis and the centrifugation, and then the lysis of the pathogens should they be present. The lysate is amplified, once again, nucleic acid. Following hybridization with probes, it is then submitted or tested through magnetic resonance. So the T2 is simply a miniature representative of MRI as you and I know it in the radiology department. It actually is detecting the water population that occurs in the processing procedure, and not just the target, and provides this magnetic field detection that leads to the presence or absence of any of these targets that I just listed. So what we do is draw a 4 ml blood sample. We load it into the platform. Once again, it goes through the procedure I just stated, cell lysis, bacterial or fungal lysis, and we're looking for target DNA. And as a result of that, the interference, as I said, is not due to human DNA, antibiotics, of course, as I mentioned. And once again, we're determining the presence or absence of these organisms directly from a patient blood sample of 4 mLs. The use of the system also requires that a blood culture be drawn within 1 hour after the T2 sample is collected. We try to highlight 30 minutes, but up to 1 hour. And it's very important that that blood culture accompany it. Our process is, if we don't get an accompanying blood culture within a specified period of time, we cancel the test. It's part of diagnostic stewardship in optimizing the utilization of a technology of this type. So several things here are important. The understanding of the results, and I'm going to take you through a few slides in a couple of minutes to show you some examples of our reports in our detection and indicate what could result in some challenges. And that's the nice thing about it. You try to figure out why did this happen or what caused this. So once again, the sample check is the volume of greater than 3 mLs. That's why we specify 4 mLs. Has to be stored properly until tested. If it's going to go over 24 hours, it is refrigerated. So you can wait 24 hours to actually test a blood sample. But that takes away from the concept of rapid diagnostics. And always the technologist has to check for clots in that sample tube. And then we go through the procedure check that can impact on the results. Common sense, if you really look at that column. And then the interfering factors. And one of those is ferriheme. Ferriheme, as you know, is used in the treatment of iron deficiency. It is an interfering factor for the Candida test. It's also an interfering factor for the bacterial test. One of the things that we occasionally see, but not often, is the contrast or MRI contrast agents, which will interfere with the T2 technology. Very important to know that. I had a pathology resident do an evidence-based medicine study on interfering factors by reviewing charts of patients that had negative T2 and a low percentage had contrast. A few had the ferriheme, and then the people on TPN are a source of negative or indeterminate results. So it's nice to know what the history is of the patient, which in the laboratory, we rarely have that information. But studies such as the pathology resident did helps us answer some questions in terms of our being able to interpret results for the clinician. We are very, very focused on diagnostic stewardship. And as a result of that, we said, if we're going to use the system, how do we use it or optimize it to gain the best advantage, or what I call the biggest bang for our buck? So meeting with the key players listed there, infectious diseases, pharmacy primarily, we decided, based upon in part, or in a large part, on our epidemiology, we were going to restrict the ordering of that test to the intensive care units, our transplant patients. I will also add our oncology to that, the emergency room, primarily in support of the sepsis program, and infectious disease. So those particular services can order the test, and infectious disease can order the test. It's not an open order test. The biggest challenge, and it continues to be because of turnover, is the training of phlebotomists and nurses in the collection of that 4 ml sample. And the company has been very supportive in coming in periodically for training of new people and reinforcing similar training to those that have been there for a while. We emphasize in every training, you must have a blood culture, a peripheral blood culture, not a line blood culture. So the bone marrow unit traditionally draws their blood cultures through lines. And we met with them and said, we can't use line draws, we need a peripheral blood. They accepted that, so now when they order a T2, they get a peripheral blood from their patients and all as well. But I just want to stress how important it is for your phlebotomist and nursing to understand what we need and the critical nature of that 4 ml specimen. And this is an example of the K2 EDTA tube. And once again, we even have a standard out on each service for which they can compare it to. Anything below 3 mLs, we will not accept for testing. And as a result of that, probably 95% of our samples are acceptable for testing. Now, as I said, it's restricted to certain services. We also took one step to say, under what service do we recommend that you order? So for example, in the intensive care units, we recommend they order the T2 bacteria. They can order both, but epidemiology says it's more likely bacterial than it's going to be fungus in that patient population. Just the reverse with the transplant and oncology, fungemia is the leading cause of bloodstream infections. They can order both once again, but we recommend they use fungemia as the primary test. Emergency room, bacterial panel, infectious disease, they can order whatever they want, either the T2 candida or the bacterial, okay? Once again, I emphasize the training of the phlebotomist and nursing in the collection of the appropriate optimal specimen. And believe me, that's been a challenge. So that's why we reinforce it every opportunity we get. And we monitor the number of rejected specimens based upon volume, and that allows us to reemphasize to our teams, you must get that. Now, a busy slide, the next couple of slides are busy, but I just want to point out a couple things here that, let me come out here in front. I'm only focusing on those that are in the bold, but you can see T2, Canada, and culture results. So you'll notice here we see T2 may have been positive, but the culture was negative. Why? Well, in our investigations, we found out that these individuals were primarily oncology patients, and our bone marrow and oncology, as well as solid organ, firmly believe that the reason the culture is negative is they think that the chemotherapy their patients are on has an impact on the viability of the organism. That's not been proven. That's a suspicion right now, but there are some studies being developed to answer that question. They also believe that gut colonization leads to a transient bacteremia as well as a transient fungemia, and that these patients are essentially asymptomatic, for what it's worth, in that group. The intensive care patients have not been that big of a problem, but overall, and I'll go to the next slide here, we can see some additional ones. So just look at the bold, and you may have some questions regarding those results. So you're going to get several possibilities. T2 positive, bacteria culture positive, T2 Canada positive, culture for fung or yeast positive. Or you may get a T2 negative and a culture positive. Most of those situations where you get a T2 negative and a culture positive are due to organisms that are not on the T2 target list. Strep hominis, some of those, and others. But once again, and you may get T2 negative, culture negative. The data that I'm showing you is from January of this year through July. And here's another slide that you can see, and see many of those organisms are not on the targeted list. But we did an evidence-based study with a pathology resident and asking the question, are blood cultures being utilized appropriately in our institution? So we drew up the criteria, the resident did chart review, we identified clinical indicators of both sepsis as well as bacteremia and fungal, and she looked at the patient's history to see if they met any of those criteria. And we learned that 90% of the blood cultures were ordered based upon fever and white cell elevation. You and I know full well that those two criteria are not reliable indicators for bacteremia or sepsis or even fungemia. So we developed an electronic ordering system about 6 weeks ago after we got the data and concluded that, hey, we have a problem, because it was interesting that 65% of the patients in that diagnostic stewardship study did not qualify for a blood culture clinically. So we developed an electronic ordering system We listed the clinical indicators for both sepsis as well as bacteremia. And as a result of that, for bacteremia, the patient must meet 3 or more of the 8 clinical indicators that we have listed. For sepsis, they need to meet 2 or more of the clinical indicators to be eligible for a blood culture. So if they don't, the algorithm goes down, do they or do they not, yes or no, and if no, blood culture is not indicated. I've also noticed since that has occurred, our blood culture utilization rate has much improved, but our T2 positivity has increased. And as a result of that, optimization, evidence-based data, presentation to the appropriate services, we're seeing a much improved, which hopefully is translating into better antimicrobial use. So in summary, I would just like to say, when we brought the instrument in 7 years ago, we put it through a rather rigorous performance analysis, and it did meet our criteria of performance. The test is available 24/7. So we, being a core lab, we have specimens that are traveling. So at 3 o'clock in the morning, if a specimen comes in from Hospital B in the southern part of the city, it is received and it is tested as it comes in. We're in the process, and my 2 colleagues here will hopefully verify that we are going to be doing some studies on asking the question, does the T2 impact on patient management, antibiotic selection? And this is why it's a partnership. So this is definitely a team effort, and for T2 to be maximized or optimized, it needs to be a team effort with the support of those respective services. And currently, this technology is the only game in town, and we're going to take full advantage of it and make sure that our stewardship is maintained at the appropriate level. And with the recent development of the algorithmic ordering of blood cultures to increase the positivity rate based upon clinical indicators, we think it's going to be a great support system to add to our overall team. So with that, I will conclude and turn it over to my favorite pharmacy colleague, Ashley Ross.
All right.
Let me get
Sure. All right. Thank you, Dr. Snyder. So we're going to go ahead and get started on the next little part of this talk. So coming into here, we're going to skip through this slide. All right, so this is going to be coming into the pharmacist perspective of real world and how we've used or utilized T2 bacteria in our hospital system. So we're going to go through a couple cases. We are limited with time, so we'll just hit some 2 very interesting cases that we've seen locally in our system. And then we'll also kind of go through some of the impactful, either current, ongoing, or future studies that are going to be looking at T2. All right, so let's go ahead and get started with patient A. So we've got patient A is a 51-year-old male who presents with acute decompensated heart failure in our cardiac center. Well, what do we know about this patient? Well, he's also IV drug use. He has hepatitis C, he has cirrhosis, and diabetes. No allergies, no other main problems other than ones we've mentioned. And on admission, he did, whether it was a true or not a true UTI, he had a positive urine culture with E. coli. So the primary team, when he was admitted, went ahead and started a ceftriaxone 1 gram IV Q24. All right, well, he's doing okay. They're evaluating things, but on day 4 of hospitalization, he starts having fevers, sepsis kind of workup. And so he is targeted to look at a septic event. What is that spike? Well, we wanted to be good investigators. We want to be good detectives in ID. So one thing that we're going to do is we're going to look at our blood cultures. What are we missing? What is happening to this patient? Why is he having this response? Additionally, we're going to order a T2 bacteria test. We want to know the answer a little faster if there's something we can do about it faster. Faster is better, right? All right, so what else do we do? Well, we also want to be safe. So in this primary team, not only are they looking for the answers, but they want to make sure that they're not missing something empirically. So for this particular patient, they brought in therapy to vancomycin and instead of ceftriaxone, escalated up to an anti-pseudomodal agent with piperacillin tazobactam. So as a pictorial, a good visualization, you can see here a timeline of what actually is happening. So hospital day 1, remember ceftriaxone was started, and that was pretty much it. Then we hit hospital day 4. We get our blood cultures first. We get our T2 bacteria pretty quickly after that. Within about 6-7 hours, like Dr. Snyder said, typically it's within the 5. This one right around 6 or 7 hours. We start finding out a little bit more information about this patient. So we know that the T2 became positive for E. coli and then also Staph aureus. The bacterial culture, you can see here, we got that done right before the T2, but it didn't result until the next day. So this is one that's also showing evidence that we have an MRSA or a Staphylococcus aureus type of infection growing now in the culture. Now, what do we do here? Well, we have a new MRSA bacteremia. We probably also have a urosepsis, likely from E. coli. That's at least what we're seeing in the rapid diagnostic portion. So what ends up happening for this particular patient? Well, we are able to de-escalate therapy. We go ahead and keep him on that vancomycin therapy, but for the de-escalation part, we know that we have an E. coli. That's where we're thinking. We have a T2 that said so. We believe it. Our patient was septic. We had an E. coli in the urine. Maybe they're linked. Maybe that was the source. But this way, this patient was actually narrowed back to ceftriaxone to complete a 7-day course for his bacteremia. So this is a good indicator of getting that answer a little faster, and sometimes it doesn't grow like Dr. Snyder showed. All right, so let's do patient B. So this is another patient, 39-year-old female who presents to the hospital. This one is going to be consulted by our bone and joint team. So what's going on with them? Well, they have a history of polysubstance abuse. They have some anxiety and depression. But most importantly, they also had a motor vehicle accident about a year ago that required some fixation devices. All right, so this particular patient, a little bit different setup. So they were empirically started on antibiotics. However, the timing I'll get to, the blood cultures were done, the T2 bacteria was done, and then the vancomycin and ceftriaxone started. And they were started later than the tests. So blood cultures done prior to antibiotics, T2 done prior to antibiotics. On hospital day 7, they had an IND done of their bone and joint infection. They also had a next generation DNA sequencing sent from that OR exam. So again, a pictorial vision or a view of what actually happened. Again, as a reminder, we had blood cultures taken. They were done, then the T2 was done, then antibiotics. So I'm going to emphasize that. The antibiotics were started after all the blood cultures. T2 came back as a positive Staph aureus. So what do? If you are the one looking at this order, the morning it popped positive, do you start therapy? Do you continue therapy? Do you stop therapy and say this is a false positive? Antibiotics hadn't started before the bacteria. It's a virulent organism. It's probably a false positive. What do you do? So just kind of be thinking of those things as we go through. The blood cultures never did grow on any of this hospital admission. So primary team continued broad spectrum antibiotics. They had that vanc, they had the ceftriaxone. ID was consulted, and we did treat it like a Staphylococcus aureus bacteremia. We did the full workup. We evaluated it further. So the next generation sequencing did result several days after the OR, and that did come back again with Staph aureus. IND cultures, again, they were done while on antibiotics, never did grow anything to confirm. We did get a TEE. So the TEE that we did based on, is this Staph aureus, because we'd rather know than miss it and be wrong. Well, we ended up having a vegetation on the mitral valve for this particular patient. So what happened next? Well, cardiovascular surgery got involved. They said, hey, we're going to investigate this. Please transfer this patient to the cardiovascular hospital. So in our system, we moved this patient over and had them further worked up for evaluation of surgery. All right, so those are just a couple of the examples that we've seen here in the last probably 3 to 6 months in our hospital system. So kind of utilizing where could we put this in play? And Dr. Snyder gave a great overview of how we thought about this process, how we implemented this process of T2. So where else could we optimize it from what we know now? Well, looking at this, where do we start it? Well, we want to think about who it's going to be most impactful for, because if it's not impactful, then why are we doing it? So patients who are septic as part of initial workup, that's a good place to start it. So think about where that might be. So in ours, it's the ED. We have it in a sepsis bundle. We have it there so it can be utilized at quick responses. You also can see it if your patient's worsening. What is happening? Why are they worsening? What are we missing? So maybe that's your point B, or your next place that you're going to look at to see T2 should you order it at this place. Again, Dr. Snyder already touched on these places. So what am I going to add to that? The who's. Well, again, it's earlier is better. So who is the one going to be evaluating this patient? Is it in the ED? Is it in the ICU? Where is it most impactful at your facility? Yes, I would say the ED in ours, probably the first place you're going to see a septic patient coming from the community. But in the ICU, the BMT units, the solid organ transplants, they also have patients that could be utilized. And yes, we do allow ID to utilize both of the tests from T2. I will also tell you, I don't use T2 as an ID consultant that often, because by the time I'm consulted, I usually have an organism which has susceptibility. So again, yes, it's a great idea, but think about who's going to be consulted first, or who's going to see this patient first to be impactful. All right, so looking at how you're going to optimize, well, you need to be aware of what's happening, what's in your facility, what resources are there to be dedicated to talk to these patients, to work up these patients, to work on the T2 implementation. Think about how implementation and education have to go hand in hand. So is that making sure that your nurses and your phlebotomists and your team members know how to draw the test, how to prepare the test, how to get the answers from the test, and who's going to respond to those said tests when they do result. And then finally, it's evaluation. So you've got to make sure whatever you're choosing to do, that it's impactful. Because by choosing to do one thing, you're choosing not to do something else, and you're utilizing those resources, and it needs to be an impactful way. So if it's not being useful, figure out why and change it. So with this, we're going to pass it over to Maddie. She's actually going to tell you a little bit about how we are evaluating some of the tests done in our facility.
All right, thank you, Ashley. Let's see. So I'm going to talk to you all about an ongoing research project we have going on at U of L Health titled T2 Bacteria versus Standard of Care Impact on Antimicrobial Prescribing. And then shout out to my research team there for helping me in the design of this research project. So looking at kind of literature gaps, we know that previous literature has compared T2 bacteria to standard blood culture procedures that utilize other rapid diagnostic tools. Some of our culture-dependent tools such as Multidisciplinary as well as Vitek technology. However, there's very limited data comparing T2 bacteria utilizing blood culture procedures with PCR-based rapid diagnostic tools such as Verigene, as well as BioFire, especially in the United States. And then another question that is kind of questionable when it comes to T2 literature is the impact on antimicrobial stewardship. So there have been a few different studies. One descriptive study conducted in 2002 saw that roughly 21% of patients had antimicrobial regimen change based off the T2 test alone. And then another more recent randomized control trial published earlier this year in May that we saw that, that kind of showed us that we're seeing more optimal antibiotic regimens earlier, roughly 30 hours earlier, when we're using T2 bacteria compared to standard blood culture procedures in our hospital systems. Unfortunately, both of those kind of primary literature studies were limited based off of small populations. So this question of does T2 have a true impact on antimicrobial stewardship is something that we would still like to see more information regarding. So our team proposed the question, does rapid pathogen identification with T2 bacteria impact antimicrobial prescribing practices in the real world setting? So we sought out to design a retrospective cohort study conducted across multiple different sites within the U of L Health system. And we're looking specifically at patients between July 2021 to July of 2024. And our two cohorts that we sought to look at are T2 bacteria in addition to standard of care blood culture procedures compared to standard of care blood culture procedures alone, which at our institution composes of blood cultures plus PCR-based Verigene as well as Multidisciplinary. So kind of a little bit about the different institutions and sites that we included in our study. So these are the three biggest hospitals that we have within our health system. Louisville Health is located downtown. It's a large academic medical center composed primarily of trauma, burn, as well as bone marrow transplant patients. And then we have Jewish Hospital, which is a large community-based hospital located downtown Louisville, consists primarily of solid organ transplants patients, as well as kind of our cardiothoracic population. And then lastly, we have Mary and Elizabeth Hospital, which is located on the south side of Louisville. That's more community-based and serves more of our rural populations within Louisville. So looking at our inclusion criteria, we included anyone at least 18 years of age with a positive blood culture admitted to a study site during the study period. We excluded our protected populations, as well as patients that had a pathogen deemed a contaminant, concomitant viral or fungal infections, as well as anyone with a polymicrobial infection. So some just additional definitions for you here. A pathogen was deemed a contaminant if it had coag-negative staph or a common skin flora deemed a contaminant by the microbiology lab. And then presence of viral or fungal infection was confirmed either through PCR, T2 Canada, or a culture. So here are some of the data collection points that we included in our study, pointing out specifically which teams are ordering these tests, which pathogens are we isolating, what source do we assume that they're coming from, if the patient had a recent history of an MDR organism that may prohibit the teams from wanting to de-escalate based off of T2 alone, whether the current organism did have some type of resistant mechanism, as well as duration of treatment, and then whether or not that antimicrobial change took place based off the T2 alone, or if we're still waiting for some of our other rapid diagnostics in order to make clinical decisions for our patient. So the primary outcome that we sought to look at was time to antimicrobial change from indexed cultures, and whether or not that change was an escalation or de-escalation. And then for secondary outcomes, we wanted to look at hospital length of stay, ICU length of stay, as well as all-cause hospital mortality. All right, so unfortunately, I don't have much preliminary data for you. Our study was just newly IRB approved a couple weeks ago, so I did kind of pull a few different patients for you to kind of gauge what we're kind of looking at within our study population. So average age, roughly mid to late 50s. We've seen included patients already across our three systems. Primarily, we're seeing that T2 is being ordered within our ED system. As Dr. Snyder said, it's included in the majority of our sepsis bundles. So that's where we're seeing most of the utilization. And then almost every single patient had an ID consult as well. Oh. All right, so as far as pathogens, the majority of pathogens that have grown so far, we're seeing a lot of Staph aureus, as well as some E. coli, Pseudomonas, and Klebsiella. As far as suspected source, most commonly seeing pneumonia and line infections. And then so far in all of the patients that have been collected so far, no antimicrobials have been changed based off of T2 alone. We've seen so far, granted, keep in mind this is a small sample, it's only 10 patients. However, nobody has made a change based off T2 alone in the patients that we've collected so far. And then here's just a breakdown of our primary and secondary outcomes, kind of on the individual level for the 10 patients that have been collected so far, kind of split up between the two groups, standard of care and T2. So we can see that average time to an antimicrobial change, we're seeing it more predominantly at that 24-hour mark, kind of a mixed bag of whether that change was an escalation or de-escalation. And then also kind of seeing that so far, the standard of care group, less patients are being admitted to the ICU, and then we're seeing all-cause mortality kind of across both of those groups there. And then with that kind of concludes our talk. So I think we have a few minutes for questions if you have anything for all of us.
Up here. Anybody have any questions? Okay. All right. Well, thank you for coming. I hope you enjoy your day. Oh, we do have a question.
Sorry, I just had a quick question for you. So I saw that patients in the, or excuse me, providers in the emergency room can order T2MR. So presumably a patient comes in, they're sick, they get blood cultures, and then they decide to get T2MR in addition because they're allowed to do that. What have you found are the factors that influence T2MR plus blood cultures versus blood cultures alone, or does everybody kind of just choose both?
I guess for me, I feel like I most often see, I've not worked in the ED, so I don't know if you would, but for me, I feel like based off the patients I've looked at so far, it's kind of severity of illness. I'm kind of seeing T2 utilized where time really does matter in some of those patients. So when we have a very sick patient coming in, we're wanting to get T2 to kind of get a faster identification of that pathogen to kind of help guide treatment and make sure we're on the right track. So that's kind of what I've observed so far.
I think to add on to that, one change that happened throughout our system was it was added to the order set or the panels. So now it becomes an easier, retrievable. The residents who are working in the ED can just simply go click, click, click and process those orders through and recommend and order those based on the sepsis type of workup that's getting triggered on our electronic medical record system. Prior to that, it was something that they had to think about. So that's another thing when we're implementing these pieces to make, you want to make the easiest thing the right thing. And so not to be confusing and not to be hard to find either. So those are things to be considering when you're adding in or considering to bring on certain tests and diagnostics. But with what we saw before, why some of these maybe didn't get a T2 done is it wasn't easy to order. Dr. Snyder said we had this, 7+ years ago. When we first started, the results were phone calls. They weren't into the electronic MAR. So to know about them, you had to get the phone call, and then it was in a note, and then it was a communication. And so a lot of things were lost in translation. The last probably 5 years at this point, we've had it in the electronic record. So you can easily find it now. We've now made it easier to order too. So I would say some of it was the fact that it was just harder to find and know to do a T2 prior. And then the last probably 6 to 12 months, we've now embedded it into a lot more easily orderable tests. Does that kind of help?
Hi, I'm Tom Burkett. I'm an ID doc based out of Cincinnati. A couple questions. Do you find that it's subject to much of the challenge you run into with next-gen sequencing where you get false positives very much that are difficult to really assess clinically? And then I was just curious if you have any sense how widespread this is being used right now as far as throughout the country, if you have any data at all you can share in that regard.
Do you want to take the second part? Okay. Go ahead. All right, we'll start with the first question first, then we'll pass it to Oscar. All right, so with the first one, let's see. How do you want to start it? Okay. Oscar, you start with this one, and then I'm going to take it back.
Sure. So we actually performed an analysis earlier. I think it was towards the end of last year. We presented it at SECM in January. And so we wanted to look at those pathogens that are T2 positive, blood culture negative. And we looked at 14 studies. And then we looked at the adjudication that was done within those studies. I think 8 out of the 14 performed adjudication. And out of those that adjudicated, they kind of all did it a little bit differently, very similar to what they're doing here, looking at other cultures, looking at blood cultures drawn on a different day. 85% of those were deemed as true infection. So from that perspective, we're seeing very low incidence of false positives. The other thing is that we don't have a lot of pathogens on our panel that are possible contaminants. So if you see them, they're probably true pathogens. You're choosing to do a T2 because the patient is in severe sepsis or septic shock, and so they're presenting clinically. And then there was, as far as where is it being used? So we have hospitals of all different sizes using T2 in the US and outside of the US, from critical access hospitals, community hospitals, to large academic medical centers. So we're seeing a wide swath across north and south of the country, east and west, and then outside of the US as well.
So anecdotally, we can give a little bit more information about like next gen and some of the other tests. We do send a lot of things out. Now, when we do next gen, it does take a turnaround time of at least 7 to 10 days on average. So this is a faster test we're getting back, and we're doing it on site. So we do get a little bit more information with that, and it does have the Canada and the bacterial species that are on the panels, so we know the information that's there. It's not everything. We realize that. So there's definitely going to be things that come from next gen that, you know, if you've seen those, for those who in the room who have seen it, it can be 25 different organisms, not usually that many, but a good 6, 7 of them, of which 2/3 of them I've probably not even seen before or heard of. So there are things in there that you have to realize, like, this is probably colonization. This is probably, it's going to pick up anything and everything. Whereas, so you really need to know when you're getting those tests, what am I expecting to get and what am I expecting to do with that result? So kind of understanding even before you do the test, is this a good specimen? Is this a sterile site? Does this normally have organisms? Does it normally have colonization that's in there? And do I have to tease it out? All those are probably yes. So with the T2, I would say most of the time, and again, this is an anecdotal answer. Hopefully Maddie's going to tell us a little bit more of how impactful it's going to be in our stewardship program. But as far as the T2, when we get a positive, we're typically going to treat that. That's probably the best answer I can say. So we're not getting a bunch of the other stuff that's out there that we might see on the next gen, but the next gen's beneficial in the sense that it does have more things than currently on our T2 panels. But we also have to wait a good week to 2 weeks to get it back.
Just comment, our oncology and transplant programs, if we get a T2 positive and culture negative, they are going to treat. They firmly believe that that is significant, and it's not, in their mind, a false positive. Scientifically it is, because the culture's negative, which is the gold standard. But they use the T2 to drive their therapies in those immunocompromised patients. And we occasionally encountered some issues with supplies. I got calls from both transplant coordinators as what is going on. I had to explain to them that we are having a supply issue, and they said, you need to get that corrected as soon as possible. So they are using T2, and they account for the majority of our volume.
Okay, thank you guys.